name is Dr. Sarah Keep from By Design Optometry, and this is Jenny, one of our staff members.
Hi.
Since I graduated in 2008, one of the biggest concerns that I have from parents is whether or not their children are going to require glasses, and if they do have glasses, how quickly their prescription is getting worse. So we're going to chat a little bit today about myopia or nearsightedness and things that we can do to prevent it from getting worse. Currently, about 28% of the world's population is nearsighted, and it's actually expected to increase to 50% by the year 2050. So it is something that we do want to pay attention to make sure that we can slow it down in children who are progressing faster than we would like.
So Sarah, can you tell me what myopia is?
For sure. So myopia is a condition where either the eye is too long or the front portion of the eye, the cornea or the lens is too curved where it focuses light in front of the retina instead of directly on the retina. When light's focused on the retina, it's nice and clear, whereas if it's focused in front or behind, it causes the image to become blurry. When we correct nearsightedness with regular glasses or contact lenses, it does center the light directly on the retina right in the center, but it centers light behind the retina in the peripheral retina, and this can actually create a stimulus that causes the eye to grow longer, making nearsightedness worse. So this is, there's treatment options where we can actually change where the light is bent to prevent the continuation of myopia.
Can I stop for 2 seconds?
Absolutely.
So it says, why do we care? Can I say, why is it important?
Yeah.
Sure.
Okay. Why is it important to prevent or control myopia?
For sure. So it's more than just the annoyance of having to update your child's prescription every year or have your child wear glasses. As I mentioned before, the incidence of myopia is increasing, and it is expected that 50% of children will be myopic by 2050, and in fact 10% of these children will be severely myopic, which is actually only a -6. The reason why we're concerned with patients over -6 is it actually dramatically increases your chance of developing diseases of the back of the eyes that can actually threaten your vision. So conditions such as retinal detachments, myopic macular degeneration, glaucoma, cataracts, they all dramatically increase in incidence in patients who are over a -6. So if we can slow down the progression, we can prevent patients from becoming severely myopic and can actually prevent some of these vision-threatening conditions in their future.
And what are the risk factors for developing myopia?
So in a child who's not currently myopic, we can actually predict their chance of developing myopia. So some risk factors are environmental risk factors. So if your child spends less than an hour and a half outdoors per day, that's a risk factor, which I know is sometimes very challenging with our weather here in Canada. Spending more than an hour and a half a day on digital devices or doing mirror work is also a risk factor. There's also hereditary risk factors. So if one or both parents are myopic, that increases their chances. Or if they're of East Asian descent, that also increases their risk factors. Age is also a factor. So if children are under the age of 9, then that is something that we do monitor them a little bit more heavily if they have other risk factors. Or if they have less of a prescription than what we would expect for their age. So children, even if they don't have a prescription for glasses, they should still be a little bit farsighted. And if they're not as farsighted as what we would expect for their age, that is actually a risk factor for developing nearsightedness.
And what if my child already has myopia? Should I be concerned?
It depends, again, on their risk factors. So for children who don't have nearsightedness, if they had 5 to 6 of those risk factors were concerned, there's different risk factors for children who are already nearsighted. So again, if they're at a young age, so if they're under the age of 9, that is a concern. If they're progressing faster than the average patient, so typically if they're progressing more than 1 diopter a year, which is 4 steps of a change, that's a risk factor. And then again, we look at those hereditary components. So if they have 1 or 2 parents who are myopic, or if they are of East Asian descent. So children who have 3 to 4 of those risk factors, again, are at a greater risk for fast progression. And this is where we really want to start talking to the parents about doing some sort of myopia control.
And what are my treatment options if I have fast progressing myopia?
So for a child who is already myopic and they are getting faster, they are progressing faster than what we would like, we can treat them with contact lenses or pharmaceutical drops. Both of these are quite effective and they do reduce the chance of progression by about 50%. For children who aren't candidates for pharmaceuticals or contact lenses, or if they're not readily available, there are treatment options with glasses. So we can either use special types of bifocal lenses or special types of progressive lenses. They're not as effective. The bifocals are roughly 30 to 35% effective at reducing nearsightedness, and the progressive lenses are only about 15 to 20% effective at reducing nearsightedness. But for patients who aren't candidates for the other treatment options, it is still a very effective option to try to slow down their progression.
Will these treatments make my nearsightedness, sorry, I'll say this again. Will these treatments make my nearsightedness go away?
That's a good question. That's something patients are often hopeful for. So once you're nearsighted, unfortunately, you will still remain nearsighted. So even with myopia control, we can't get rid of the nearsightedness that you already have. The goal is to slow down the progression. So when I say a successful case of myopia control is a 50% reduction, that would mean that if your child is getting worse by 1 diopter a year, which is 4 steps, if we can slow that down to a half of a diopter, which is 2 steps, that's a 50% reduction. So in fact, a successful case of myopia control, you will still be nearsighted and we will actually still see a little bit of progression. From 1 year to the next, it will just be significantly less. And this can sometimes be discouraging for parents and for patients who are undergoing a myopia treatment, but it's still very important to pursue myopia control, because if we can slow down how fast patients are getting worse, it can actually prevent them from getting into that severe nearsighted range, which significantly will reduce their potential of developing diseases of the back of the eyes. So even if your child still ends up being nearsighted, if they can end up more of like a -3 or a -4, that's much more manageable than if they end up being like a -6 or a -8.
Great. Sarah, can you tell me about contact lenses for myopia control?
For sure. So contact lenses are one of the most popular options for myopia control in the office. So in a standard contact lens, the purpose of the contact lens is to focus light directly on the retina. But as I mentioned previously, in these lenses, there is light in the peripheral edges of the retina focused behind the retina. So in a myopia control contact lens, we still have to correct the prescription. So there's a component of the lens that will clear your vision. But there's a treatment zone going 360 degrees around the lens that pushes light in front of the retina, basically removing the risk factor that stimulates the retina to grow longer. So these treatment options are very effective for patients. We do, as I mentioned, we typically see about a 50% reduction. Children are often very successful in contact lenses. We do a lot of patients at a young age, and they do very well with contact lenses. The chance of risk factors is quite low. We often will start patients in a daily disposable contact lens. Patients are often concerned about eye infections with lenses. The chance of developing an eye infection in a daily disposable lens is much lower. And in fact, the average population who doesn't even wear contact lenses, their chance of developing an eye infection or corneal infection is about 0.14%. And in a contact lens over 10 years, it's only 0.42%. So even though it is a slightly greater risk than a non-contact lens wearing population, it's still less than half of a percentage over 10 years of developing a corneal infection. So we have very good success with contact lenses.
And tell me about glasses for myopia control.
Some patients, if they're not candidates for contact lenses, we can control them with glasses. We would do a special type of bifocal called an executive bifocal, where there's a line that goes over the entire bottom portion of the lens. It is very important to get that line right from the edge to the edge of the lens, because that's your treatment zone. So if you do a smaller bifocal, you're making the treatment zone less effective essentially. So light that passes through this treatment zone, again, is focused in front of the retina. Because the treatment zone is only in the bottom half of your vision, it's not as effective as a contact lens where the treatment zone is 360 degrees around your area of vision. So the effectiveness is a little bit less in an executive bifocal. So we're seeing about 30 to 35% reduction in nearsightedness in an executive bifocal. The other option, some patients don't want the line in the lens or have difficulty finding an executive bifocal. You can also do special types of progressive lenses. The effectiveness of progressive lenses, again, is not as good as the executive bifocal because the treatment zone is much smaller. So we're only seeing about 15 to 20% reduction in nearsightedness in patients who wear progressive lenses designed for myopia control. But for a patient who's not a candidate or not willing to try any of the other treatment options, then some myopia control is better than no myopia control because it's still possible to prevent them from developing severe myopia.
Great. And then tell me about atropine for myopia control.
For sure. So atropine is a pharmaceutical drop that we prescribe for patients for myopia control. It is prescribed in a low percentage, so lower than what's typically found at pharmacists. So you do have to get the drops from a compounding pharmacist. Again, it is very effective for myopia control. We're typically seeing about a 50% reduction in the progression of nearsightedness. Most patients do quite well. There's very few reports of side effects. The most significant side effect we would see is like an allergy type reaction to the preservatives in the drops. Patients can sometimes also get a little bit of pupil dilation, which can cause light sensitivity. It can also minimally affect their ability to focus up close, but these effects are extremely mild with the low concentrations that we typically use for atropine, so we do typically have very good tolerance of the drops. It is something that patients have to be on long term, so they do have to take the drop every day for a span of 1 to 2 years, potentially longer. Some patients aren't comfortable doing pharmaceutical drops in their children for that length of time, so if that's the case, we would do other treatment options. One of the other things we take into consideration with atropine is the fact that there can sometimes be a little bit of a rebound effect that once we discontinue the drops, some patients do have a period where they'll progress shortly after discontinuing the drops. So these are things that we always take into consideration when we choose what treatment is most appropriate for the patient. And sometimes we can actually also double up on treatments. So if we're still seeing more progression than what we would like, we can combine things like contact lenses with atropine or contact lenses with backup glasses and stuff like that as well.
And how do you determine if the treatment is working?
Any patient we have on myopia control, we do monitor them more regularly than the average patient. So they typically come in every 6 months for a follow-up. We'll double check their prescription at this point and take some additional measurements on the functioning of their eyes, and we can actually calculate the rate of progression. So we go through and do a calculation on how fast they were progressing before treatment, and then we compare that to how fast they're progressing after treatment, and we can determine how successful they are. Thanks for joining us, everybody. Again, I'm Dr. Sarah Keep from Vision by Design Optometry, and this is Jenny. Thanks for joining us as well. I hope you guys found that to be informative and useful for potential myopia control in your future. If you like that video, feel free to subscribe to our channel or give us a thumbs up, and we'll post lots of additional videos on your eyes and eye health.